In terms of the foundation of our services, again, revisiting the concept of Tawheed, the tradition of the Prophet ﷺ, we look at the Quran when we invoke Allah subhanahu wa ta'ala for dua to heal the patients and to guide us and to guide them as well. We look at examples in the hadith, either hadith Nabawi or hadith Qudusi. We look at the seerah of the Prophet ﷺ, and we look at the history. In our history as Muslims in the 6th century, immediately after the death of the Prophet ﷺ, the Khalifa Umar radiallahu anh, established a trust, a waqf, called it Waqf Mu'nis al-Marda. Basically the person who offers solace to the patient, comforting the patient. So we have a history in our tradition that we offer the service, and we see ourselves as a continuation of the prophethood, of the continuation of the tradition of the Prophet, following his footsteps, and we look at our own history as Muslims to follow those before us. Some of the things that we do, again, all this is recap, is we comfort the patients with, but we don't give them false hope, because we don't know what is happening. We deal with issues as we have it on a daily basis. We acknowledge the concerns of every patient. We don't rush to solve it by offering them a way to be patient. We recognize their concerns, and their concerns are real to us. And when we promise something in terms of services, we promise something within what we are able to do, without any preferential treatment. If I'm going to offer someone a daily visit, that means I will be visiting every single patient in the hospital unless that patient has something different. The goal of our service is to be there with someone, not to save or fix their problems. Some of their problems are beyond our fixing. And one of the ways we connect with patients is we tell them how we know how they feel. Basically, from the information, we don't know how they feel 100%, but that is our attempt, is to know. And that's why we don't say that. And we reflect on our experience with our colleagues. That will give you this slide, the size of the spiritual care team at Stanford Hospital. Starting from the director of spiritual care, the director of education for spiritual care, then we have coordinator of volunteers, we have an intern, we have a student who is student supervisor. My sister Taqwa, she's the cancer care specialist on our spiritual care team. We have the decedent care team who's in charge of every single person who, before they die, that's offering end-of-life care. We have a priest who offers care to the Catholic patients, our secretary. We have the students. We have every year 4 students who come in for a 1 full year program. We have 8 summer students who would come in for 14 weeks, every single summer from May till the middle of June. And those 86 students come in from September until September the following year. And you see me on this panel here, those are the on-call chaplains who are from different faith communities. They come in whenever they please based on a schedule. So I'm not there every single day. You ask to be assigned to the schedule. On top of that, we have 250 volunteers who go into the hospital every single day. When I say this care is available 24 hours, 7 days a week, we have a system. And if you have a hospital like Stanford who has 900 beds, you better have an army of people because the needs are overwhelming you will not be able to provide the service as one person. You don't have to be paid. All of these people don't have to be paid. At least we have volunteers, Muslim volunteers. I have 25 volunteers. That means I guarantee there'll be one Muslim every single day in the hospital to visit the Muslim patients that we have, which range between 2 to 4%. Close up to 20 patients a day. That's a good significant number for one person to make 20 visits in the hospital. In terms of hierarchy, spiritual care is directly reporting to the Office of the Vice President for Quality Control in the hospital. It's about quality of services, and that's why spiritual care is to enhance the quality of life for our patients. We have a director, spiritual care supervisors, which I introduced to you. We have the cancer care unit, and the emergency room have one person dedicated to those two units every single day, and every faith community is encouraged to establish its own program. I did mention the 2 levels of students or education: intensive summer program that is 16 weeks, and 3 sessions per year for the residency. Some of the training, in order to have competent spiritual care workers, we have to train them. The number one requirement that we have once we accept a person is to go through the infectious control and to have a certificate that this person can go into the hospital, get a TB test, get all of these aspects of care that make sure that this person is safe to be in a healthcare environment. Once we do that, and this is partial in terms of what we do, we offer them education, how to access medical records, including what language you're going to write. Keep in mind, in a Western environment, medical records belong to the patient. Maybe here as well. Medical records belong to the patient at all times. They have the right to request a copy of their medical records. So you better be professional when you write about the patient, including when they're difficult. So you will have to maintain professionality in all time and write information that is only relevant to the interaction that you have. The second one, when we conduct a visit, there are certain levels of visits that we do. There are visits that are initial visits that we have to chart that this is an initial visit to do an assessment, or to either can be a follow-up visit. After that can be a referral by a healthcare professional. It can be a consult, it can be self-referral from family or patients. Every interaction, every time you visit a patient, you chart. The visit that you don't chart, to us in the hospital, means that visit never took place. So if you're going to document how many visits you have, you better have every visit be documented. Now, what you see here on this side is the date I was on the hospital, and we put down the date, documenting every interaction. We put down the name of the patient without disclosing everything. The code here. This is basically a page that I received. This is an advance directive that I have to fill out a legal form for the patient to tell us what they want to do in the course of their treatment. On this side, we have a C code, rapid response. D is for mortuaries. P here, a patient passed away. So basically, you document every single interaction you have in the hospital, and Islamically, this is part of muhasabah. Are you responding to codes inside the hospital or not? Are you writing down where you are, in which unit, what time of the day and the night that you're there? Now, assuming this patient here that I visited need something for the following day, but I will not be in the hospital. On this side is notes that we write from a spiritual care provider to another. Basically, when you do sign out, then we put example of what exactly they need. The person who completed immediately after will sign here, and the case is closed. So we have a sign out from one person to another. None of us work independently in the hospital in the sense we do whatever we please. No, we are part of a team, whether we are part of a medical treatment team, and we're part of a spiritual care team that we do sign out to our colleagues as well. What do we receive from the administration? It's electronically, but also we get a printout. Every single day we receive a list of every single patient in the room, their full name. We receive where they are, what room, what age, sex. Upon admission, our the admission staff asks about the faith of the patient. So we have a census of who the patient, or we have a sense or an idea who the patients are. Some of our patients don't answer the question. We visit with them to make sure that we know who they are. Number of days they have been in the hospital, diagnosis, and remarks as well. When we have that information, we already have a picture about the patient himself or herself. So when we walk in, already we have enough information to help in the assessment of the patient. This is in terms of what was accomplished here in Malaysia. We started with Dr. Ishaq 5 years ago or 4 years ago, and Malaysia adopted the Ibadah-Friendly initiative to be in the hospitals, hired 60 Ustaz and Ustaza. We have organized many training seminars. Is this the end? Is what we have sufficient? Or can we entertain a different way of doing the work? And there are certain models that are done in the West. Number one is the clinical pastoral education known as CPE. Pastoral basically is a religious grounding, and this is the spiritual care program that we do. Every unit, remember the students I told you we have 8 students who do residency for 1 full year. The 1 full year is divided into 400 hours every unit. The first 300 are clinical and 100 is theory. So we give the theory of spiritual care. We give didactic. For example, we'll bring in the social worker who talk about what social work in the hospital and what does it mean, what does a social worker does. We talk about being an oncology or a caseworker. We talk about nursing, we talk about a physician. We bring all these professionals to talk to spiritual care worker about their work. We engage them in discussion. The 300 are done by the students or the spiritual care workers by themselves. They visit with patients and they implement the theory that we teach them in terms of spiritual care. On top of that, they get 1 hour every single week with a supervisor for an individual supervision. That's where they bring any issues that they are dealing with, including difficult conversations. They can request that individual supervision at any time. For 2 hours a week, the entire team meet together. Those who are doing the 400 hours as a team, we accept about 4 to 5 every single unit. The team meet together and it's their time. They discuss aspects of their training independently. We don't interfere. We're there basically to offer them the space, and they offer, this is a time for bonding with each other. I look at that as similar to the USRA program that Dr. Ishaq is doing here in Malaysia, which is a time for bonding in the team. The only difference, What you do is spiritual component, this is professional component in the sense of what's happening in the life of the individual. Verbatim is a Latin word, it means word by word. So every time we meet, I mentioned that we don't take anything inside the patient room to write. So we ask to sharpen the tools, the listening tools of the spiritual care provider. We ask them to write about the case, a visit that they conducted in the past week, to write it verbatim, what happened, including description of what they entered, what they found, what the room smells, who was there, and it's a dialogue, patient, spiritual care provider, one by one, sentence by sentence, give us about a 10-minute dialogue between the two. Why do we do that? Because we want to monitor what is happening inside the room between the spiritual care workers and the patients. That's number one. Number two, we want to monitor their response based on their self-reporting. What happens most of the time, and that's the human instinct, is you write about the perfect visit. So immediately we will be able to know what the person basically is not reporting about, and we challenge. And this is a time where you confront your team because you care about their presentation, you care about their performance, and you care about their patients. Then we do a lot of role play. We take roles of one being a patient and one being a spiritual care provider to sharpen our tools within an environment that is safe, our team, that when we go into the patient, we'll be able to predict things and to learn from our own mistakes. Recently, we have in the US a program that offers a certificate in palliative care that is spiritual care certificate. For Husn al-Khatima or end-of-life care, it's an 8-week online program that you go through didactic online for 8 weeks, and you have 1 week to continue the work on your own. So this is another way of introducing a specific discipline to spiritual care that the person will be more specialized. We also offer board certification. Board certification in spiritual care through the Association of Professional Chaplains in the US. The requirements are the following: education to have a minimum of master's degree or equivalent, completing 4 units of clinical pastoral education, complete 2,000 hours of patient care outside of the clinical education, complete an application with all the essays related to your own competence as a spiritual care provider, and sit before a panel of spiritual care supervisors who will discuss if you are relevant to be board certified or not. And you'll be assigned a mentor for life that will be visiting with you every single year to discuss areas of recertification. That is, in a nutshell, part of what we do in terms of documentation, in terms of professional development of our spiritual care workers. Can something like this be done in Malaysia? Absolutely yes. In the past 4 years, I've visited Malaysia for about 5 times. And we introduced the concept of spiritual care at every visit. Then there are twice that we offered intensive programs, and some of them were here with us today. The intensive program where we went inside, we did not do a conference like this. We went directly into the hospital and we discussed cases, we visited with patients, we did rounds, and that was very successful in my opinion, but it's not sustainable. We cannot do something like this every time. The requirement to have the pastoral education or CPE is for you to put aside 3 months for every unit, which in the case of having a person with family here in Malaysia is difficult to do. We cannot take you out of the environment to take you into an environment where A, you don't speak the language, and B, you're away from your family, away from your job. So we came up recently with another way of dealing with training of Muslim professionals all over the world. We have an online curriculum. Basically the 300 hours or 400 hours that are required, you will be doing 100 hours online and 300 hours in your own hospital, the way you do every single day, with the addition of the requirements of writing case studies and discussing them. Also, we'll be sending retired spiritual care supervisors who have retired from hospitals in the US and now enjoying their retirement. They can be sent here, they be monitoring some of the students. If this is something that is worth looking at, that's something I encourage you to look with your, or to visit that with your supervisor in the hospital, as well as with your hospital management. I prepared a video. Actually, I came across an interview of former President Barack Obama. He was talking about his own presidency and what it takes to be a president. Now, we read the Quran as Muslims, and we take verses from the Quran and we look at them through the light of our own professions to see, these verses speak to us in a way, do they apply in our conditions? I look at this interview, I thought it's very important for you to listen to 3-4 minutes or less and to reflect on it for your own sake as a spiritual care provider, as a nurse, as a physician, about the profession that you choose. Let's hear it.
Things in relation to the Prophet or the Quran because they're an atheist, or they may be anti-Islam to begin with. Number one. Number two, for example, we've also got situations in the country where they have very protective children who insist that we don't tell the parents or the mom or the dad who has a terminal disease. They say, if you tell my mom, she'll go into depression, she won't eat, she'll be in a worse off state, so please don't tell her. Thank you.
Sure, you don't have easy questions. Thank you so much. For the first question, what do patients want when they share with you their anger and frustration? Is number one, a person who would listen. Listening, affirming, recognizing, telling that person, the person is, I understand that you are angry. They're not looking for solutions. That's our problem, is when we hear something, we want to jump into solutions. There are certain problems that cannot be solved. The patient who is angry has a foot that was amputated because of diabetes. They have every right to be angry, frustrated. On top of that, they think it's a doctor's mistake. Okay? So they meet with you, the first person, and they empty all that load of frustration onto you, and you better be there like a sponge who will just absorb it, not release it. I mean, do not reflect it back. All what I say is, I'm really sorry. Often, that sorry for that you are upset. I don't apologize for something else because there is nothing I have done that is wrong. So acknowledging that by saying, I'm really sorry that you're upset. Is there something I can do to make it right for you? Is there something I can do to help you out have a better day today? Engage them with something instead of moving on. That is an approach to it. If you realize that the visit is becoming hostile, keep the distance and you're the professional, you can end the visit at any time. And tell them, it seems that you're very angry today and it's better if we come back and visit with you later on when you calm down. Because there is no need to be with a hostile patient. That's number 2. I forgot already the second question. Yes, on the aspect of encountering families. I remember being in Pakistan, subhanAllah, with the first half. And we did a pre-convention talk. And I challenged physicians with this fact, unfortunately, that for cultural reasons, physicians do not, I didn't say me as a physician, but physicians do not share the diagnosis with their patients because of cultural pressure. I gave the analogy to the physician himself. I said, Allah subhanahu wa ta'ala gave you knowledge of the body, the wisdom to know when there is multiple organ shut down. And if you know in the next 48 hours, not more, your life will be over, how would you like to spend your life? When I presented that this way, the physician could not hold himself. And that's one thing I approach with families. I said that the patient already knows that there is something wrong with them. There is something wrong with their body. That the disease is going to overcome them in terms of shutting down multiple organs. Maybe they have something on their mind. Maybe there is some wish that you would like us to do. Maybe there is a place that they would like to visit. Maybe there is a relationship they would like to mend. When Rasulullah sallallahu alayhi wa sallam in his last 3 months, the last surah that was revealed by Allah subhanahu wa ta'ala was Surah Al-Nasr. That is the pronouncement of the nearness of his death. إذا جاء نصر الله والفتح ورأيت الناس يدخلون في دين الله أفواجا فسبح بحمد ربك واستغفر became the issue of tasbih and istighfar. It's the end of life. And that window of tawbah, repentance, and istighfar is open to the patient as long as they are breathing until the end of life. That opportunity that Allah subhanahu wa ta'ala is giving them is no longer there. So who am I or the family to deny that patient something that Allah subhanahu wa ta'ala gave to them as right at the end of their life? That is the talk I would be having with the family. The only difference I would say is when I share with them the news, I'll guarantee that I'll be gentle in providing the message. And I'm sure they'll be upset hearing the news, but having the truth at the end of their life is better than dying without having the opportunity to repent. I have to fight for that patient. We have to. If we are to consider ourselves an authority representing what Allah sent to us through the Prophet, we have to fight. If we don't do that, we have failed our commitment and we have failed the patients who are trusting us.
Can I also ask that if your background is more on religious knowledge, and even when you have access to the medical notes, your level of understanding, will it be different from, say, a psychiatrist who's reading those notes? What I'm trying to say is, in terms of benefit, if the patient had to see somebody because he's depressed or upset, would he gain more by seeing a chaplaincy or to see a psychiatrist?
I don't consider myself as a counselor, yet I counsel people. Within the professional boundaries, I'm allowed to be about 3 sessions with any patient. Yet if I discover during that assessment, the 3 visits, that there are issues beyond my ability, require a counselor, I have the obligation to refer that patient out to a counselor. And in this case, I offer it to the medical team to say, I believe that this patient deserves a psychological support beyond my services as chaplain.
Thank you very much.
You're welcome.
Any other questions? Okay, there's no questions. I would like to invite.
Terima kasih Dr. Reni. Assalamualaikum warahmatullahi taala wabarakatuh. Alhamdulillah, rabbil alamin, wassalatu wassalamu ala asyrafil anbiya'i wal mursalin wa ala alihi wa sahbihi ajma'in. Yang saya hormati dan muliakan tamu kita, I think tadi pagi Datuk Rahman Jamal yang buat pembukaan, saya kena buat penutup ya. Mr. Kamal from Stanford. How do you find Malaysia? Alhamdulillah, very good ya. Kemudian rakan baik saya juga Profesor Rohaizah, Ketua Pusat Islam Kampus Kuala Lumpur. We also have our senior veteran Dr. Ishak Masud. Orang kuat Abim dulu, saya ingat dia masa dekat UK dulu ya. Met him in the UK when I was a student. Of course, my dua timbalan pengarah dia, Prof. Datuk Razman dan juga Profesor Halim, rakan-rakan ketua-ketua jabatan dan saudara dan saudari sekalian ya. I think you've had a very long day. I think you had a very good educational discourse today from the feedback I heard. So I thank everyone, and I thank especially the speakers. Some come from very far away. Kita nak terima kasih kepada Profesor Rohaizah for this very interesting, innovative program. Juga kepada yang berusaha, Dr. Ishak, I know that all this is your hard work for more than 20 years, I think. Dulu Dr. Ishak pun ada datang jumpa saya and we are committed making this hospital a truly hospital mesra ibadah. Tepuk tangan dengan saya, I think Prof. Raizak ni apa ni ya. I think definitely as pengarah, I've just taken over this post in the last 3 months. As pengarah, we want this to be a better place. We want this to be a place where we value not just medicine, not just the physical wellness. We talk about wellness and not illness. We want to look at the spiritual wellness too. We talk about end-of-life care. We talk about better, faster, and more friendlier services. We talk about all the good values that Islam teaches to be a better practitioner of health, not just medicine or surgery, is the total health. So itu adalah komitmen kami. InsyaAllah kita sama-sama berdoa supaya we can make this hospital a better place, an example to all the other hospitals across the country. And kita sama-sama lah berdoa semoga Allah memberi kita hidayah dan petunjuk ke jalan ini lah. So I don't want to spend too much more of your time. I would like to again say on behalf of hospital sebagai tuan rumah, kita mengucapkan terima kasih kepada penganjur dan kita juga memohon maaf sekiranya berlaku sebarang kekurangan. Any of our witness dalam menganjurkan ini, kita memohon maaf. Sekian saja. Wabillahi taufiq wal hidayah. Assalamualaikum warahmatullahi taala wabarakatuh.
Waalaikumsalam.